here. Okay, so thanks for joining today. Essentially, we're going to go over a couple of the updated protocols that have been passed through CPC since we last spoke, quite a while ago now. So today we're going to focus on some of the limited body exams, which are mostly just modifications of our standing body protocol, as well as some pediatric protocols that we've set up, which again we already do a lot of, but just a couple of notes around them, a little bit more detail. In terms of the OB and MSK, the MSK, I think we're still, they've been passed through the CPC, but I think they're going to require a little bit more hands-on training. So we're going to set up some in-services with the techs that do MSK at each of these sites to go over those updated protocols. So again, the objectives of this was to just kind of standardize and harmonize what we're doing at all the sites, and provide some guidance in terms of technical considerations around obtaining the best possible images, and as well when limited or expanded exams can be performed. But as always, don't hesitate to speak to whoever the covering radiologist is. Any questions, despite what's detailed in these SOPs. So some of those newly approved revised protocols that we have, there's a few limited abdominal examinations that we'll go over, and then the pediatric exams, and then these MSK exams that we'll go over at a later time in person. And these obstetric protocols have also now been or are on the board to be passed through CPC as well. So some quick notes that were included into the abdominal SOP. So a revised abdominal SOP was passed through CPC that has a couple of these notes around performing limited exams in the setting of certain clinical indications or follow-up. So with regards to follow-up of benign pathology, so we're talking about, liver, renal cysts, gallbladder polyps, hepatocholangiomas, those types of things. The suggested examination now is just a limited exam of the target organ of interest as per the specifications for that particular organ in the general abdominal SOP. So, no real need to include the kidneys when we're just following up a gallbladder polyp. It can focus on the gallbladder. I don't think it's that much more to include a quick assessment of the liver if you so wish, but for the most part, we just need to be following up the organ of interest for that particular benign finding. Similarly, if there's an abnormality that's identified on some other modality, so CT or MRI, and they want further characterization of that particular abnormality that was seen on that other imaging modality, we can again perform a limited examination of that target organ, again as per the specifications in the general abdominal SOP. But this can only really be performed if the other imaging was performed in the last 3 months, and the images are available on our packs. So, if again there's some abnormality that was seen in the kidneys that requires further characterization, that was seen on a CT that was done a few months ago or 2 months ago, and we're now doing an ultrasound to further characterize that renal abnormality, a full abdomen is not needed. You can just look at the kidneys. In regards to, again, further evaluation following a cross-sectional examination, in this case, when there's a negative CT or MRI, so no abnormality was found, the patient presented through ER, had abdominal pain, had a CT, they didn't see anything on the CT, but for whatever reason, the patient was admitted and is now, they're now requesting, again, investigation for pain in the right upper quadrant. If that negative CT is within the last 1 week, if performed through the ED or inpatient, or within the last 3 months as an outpatient, then a targeted exam can be performed either of the organ of interest based on the clinical indication, or the quadrant of interest, again, based on the indication. So, if it's right upper quadrant pain following a negative CT, no need to look at the spleen, don't really need to look at the bladder or lower quadrants, anything like that. And then the only other thing that was included in that general abdominal SOP with regards to kind of limiting our exams is often we'll get requisitions, particularly the paper requisitions, where the ordering physician will order a abdomen and pelvis ultrasound when the question is about a specific organ that's either in the abdomen or in the pelvis. They just tend to lump these together, and I don't think that it's necessary to include a gynecologic pelvic exam when the question is about gallbladder polyps or something else within the upper abdomen, for example. Obviously use your judgment with regards to this. If it's more when we're talking about benign pathology, if the question is cervical cancer or something like that, then I think it's perfectly reasonable to include the abdomen to look for metastatic disease in the liver, or so on and so forth. But if it's something that's benign and pelvic related, then no real need to include a full abdomen. But if there's ever any question, really just consult the radiologist who's on and covering ultrasound. So going on to some of the actual written out new limited SOPs, there's a new limited AAA SOP for follow-up or investigation for abdominal aortic aneurysm. It's a little bit more extensive an investigation of the aorta than we currently do, but otherwise should require overall less time because we're not including a full abdomen as we currently do. So in terms of the images that should be obtained of the aorta, generally we're talking sagittal and transverse images of the full length of the aorta, representative images on sag and upper mid distal, with and without color Doppler, transverse really just proximal and distal, some AP and transverse measurements on the transverse. If you do encounter any aneurysm or significant stenosis of the lumen, so anything greater than 50% stenosis, then measurements should be obtained at the level of the aneurysm or hemodynamically significant stenosis. Obviously, as you're looking through the aorta, you should be looking for the patency of the aorta, any significant calcifications, plaques, thrombus, dissection, stenosis, anything abnormal, beyond just the normal minimal atherosclerotic calcifications. Obviously obtain representative images if seen, and then just a single image in long axis of the proximal IVC. And one thing I would just mention is for that proximal image of the aorta in SAG, ideally should include the origin of the celiac trunk and SMA, just again with the color Doppler as well, just showing nice patency of the origins of those two vessels. In terms of the limited spleen SOP, which is new as well, this is mostly for indication of splenomegaly. Most of these orders are coming from hematology, and I find that a large majority of them go to Q site. I don't see many at M or C, but you may get them occasionally. So again, for either for splenomegaly or hepatosplenomegaly, those are kind of the main indications you would use this SOP for. And for the most part, it's limited spleen and liver as well as lymph node screen. For the spleen, this is similar to what we would do on the routine abdomen. So just transverse images of the superior, mid, inferior kind of spleen, sagittal image through the hilum with and without measurement of the splenic length. And then if it's relatively well visualized, you can obtain a 3D volumetric measurement of the spleen. Liver, again, a routine liver as per the abdominal protocol, and then just a quick screen for any abnormal adenopathy, just obtaining some representative images in the periumbilical abdomen and the 4 quadrants. I would say document any visualized lymph nodes that you see with representative grayscale images, but you can measure maybe the largest lymph node, but for the most part, normal nodes, you don't need to give 3D measurements of every single node you see, but I would just say measure the largest or any abnormally enlarged nodes. Then I would suggest obtaining measurements for those. And then for any abnormally enlarged nodes, I would also obtain a color Doppler image of that largest node. Another one of the new limited abdominal exams is a hepatobiliary SOP, which is fairly similar. So really, it's just the HCC SOP, and for jaundice and cirrhosis, I would still just do the routine HCC SOP. So for those kind of routine follow-up cirrhosis cases, but if you get an indication of abnormally elevated LFTs, so or they specify the specific abnormal liver serum test, then you can do a limited hepatobiliary examination, which would be the HCC protocol as well as the images of the pancreas in accordance with the abdominal SOP. So essentially just looking for any pancreatic obstructing masses. But for the most part, again, relatively limited for this particular indication of abnormal LFTs, really no need to include just kidneys. And then one final limited abdominal protocol that we've now introduced is a right upper quadrant pain SOP. So for mostly these are going to be coming from the eMERGE for specifically right upper quadrant pain, or when they specify in their indication query cholecystitis, choledocholithiasis, anything like that. For the most part, again, limited as per the abdominal SOP of the right upper quadrant structures. So liver, gallbladder, and biliary tree, pancreas, and then also make sure to include the right kidney as well. Just looking for any hydronephrosis, stones, anything in that region. So you're dropping out the spleen, bladder if they've also included the pelvis in their order. So that's pretty much for the abdominal protocols. I think we're doing okay on time, so maybe I'll field any questions about those if there are any. I'm just trying to see, can't really see the comments here if there are any. Yeah, I don't see any questions. If anybody does, feel free to type that in now. If not, we can always come back to it at the end of the talk as well. So if there's nothing, I'll move on to the pediatric protocols. Starting with the neonatal brain. Most of your imaging is going to be through the anterior fontanelle with curved or phased array transducer, kind of medium frequency. There's routine images that I'd like to see on every single study done. Obviously, including more images is not going to be held against you, but at the bare minimum, there are 6 images that should be obtained as a standard while sweeping through the brain in coronal plane. So just looking through these quickly, an image of the bilateral frontal lobes anterior to the frontal horn. So you really shouldn't see the frontal horns here. So we're just anterior to those. You should see the echogenic bony ridges of the bilateral orbits. So that's the first image. As you come posteriorly through the frontal horns at the level of the interhemispheric fissure between the 2 frontal lobes, obtain an image here. Progressing posteriorly through the lateral ventricles at the level of the 3rd ventricle, roughly in the region of the foramen of Monroe. This would be your 3rd image. Continuing to sweep posteriorly, just posterior, well, not just posterior, but posterior to the foramen of Monroe at the level of the thalami. You'll start to see the brainstem as well. So pons and medulla start to get a little bit of the fourth ventricle choroid as well down here. So this will be your fourth image. Your fifth image is just posterior to this. Once you get through the bulky portions of the echogenic choroid plexus within the ventricular trigones. So this is where you're really a little bit more sensitive with regards to increased periventricular white matter echogenicity in the setting of PVL. This is a useful image also in the SAG, but here you start to see it as well. And then just posterior to that, through the parieto-occipital lobes, but beyond the lateral ventricular trigones. Also in the coronal plane, using a linear high frequency probe, this is something that we don't do all that commonly now, but I'd like to see as a part of the routine neonatal brain. Take a look at the extraaxial spaces, so the subarachnoid space outside of the brain. This should be obtained in the midline, usually in along the superior sagittal sinus, anteriorly within the region of the frontal horns. And an image should be obtained of this region both with and without color Doppler. If you see an extraaxial fluid collection, or there's a question regarding an extraaxial fluid collection, then if you see a fluid collection, obviously measure it, and more extensive interrogation and images should be included of that, including as well a standard measurement of the distance from the dura to the pia mater of the adjacent frontal lobe. In terms of the sagittal images of the brain, as a standard, there should be at least 5 images sweeping from left to right by standard, again from left to right, and should be clearly annotated as such. So really there's 3 separate types of images, but 2 of them are duplicated on either side of the midline. So first, on either side, lateral to the lateral ventricles, through the level of the sylvian fissure and insula. Coming just medial to that at the level of the caudothalamic groove, where we're looking for germinal matrix hemorrhage. And again, this is on either side of the brain. And then one in the midline sagittal view showing the corpus callosum, third and fourth ventricle, cerebellar, vermis. So just a couple of notes of some additional imaging that may be required depending on what you encounter. So the updated protocol gives some further details on what to do in the event that ventriculomegaly is encountered or suspected on the examination. Regardless of the presence of or absence of germinal matrix hemorrhage, measurements of the ventricles should be obtained in these cases and should be done in a standardized fashion. So to obtain some standardized measurements can be obtained for ventriculomegaly in the neonatal population, and the standardized measurements vary depending on whether or not the baby is premature, under 40 weeks of gestation, or at or beyond term. So for the preemies, measurements should be obtained at the level of the third ventricle, just posterior to the foramen of Monroe. So essentially that's around the image 3 or image 4 of your standard coronal images. And a measurement is obtained between the falx and the lateral wall of the lateral ventricle at this level for both ventricles. And that gives you the Levine or ventricular index for each side. So this is useful for following ventricular caliber on serial examinations in a very standardized way. And there's also nomograms available for this index based on gestational age. In the coronal plane, you can also obtain a frontal horn diameter by measuring the diagonal. Can you all see my mouse cursor, or do I actually have to put on cursor selection. Can you see my mouse cursor moving around?
Yep.
Okay, so essentially you'd be looking to measure the transverse diameter of the lateral ventricle at the widest point. Let me see. It can be a little bit variable, and that's why I don't love it, just because it depends on what you determine to be the transverse axis. So, some people might measure it like this, some people might measure it like this. There's a little bit of subjectivity in that. So I would default to the Levine index, but if you wish, you can also obtain that transverse measurement at the widest point. Ideally, the most accurate is actually a 3D volumetric measurement of the ventricle at the widest point, but I don't know if that's technically feasible with our variable machines. So here, this would show kind of that transverse axis. For term babies, the image is obtained at the same level as in the preemies, so in the region of the third ventricle, just behind the foramen Monroe. And here you would obtain a ventricular hemispheric ratio, which is a ratio of the lateral ventricular diameter from the lateral wall of one ventricle to the lateral wall of the other, relative to the transcalivarial distance, so between the inner table of the calivarium at this level to the other inner table. And again, this can be used to sequentially follow the ventricular caliber if needed. So just a couple of specific indications that you might encounter and what additional images or what imaging should be obtained in those cases. So if the indication is for craniosynostosis or some other description of abnormal skull morphology, high resolution linear imaging of the scalp and skull needs to be obtained, obviously, which would include images of all of the major skull sutures, including coronal, sagittal, lambdoid, and metopic sutures. Representative images should be obtained of each of those sutures, obtained in transverse relative to the long axis of the suture, showing the normal alignment of the bony plates, as well as the normal hypoechoic fibrous gap between the bone plates. If any abnormality is noted in the normal hypoechoic gap, or in the osseous ridge, then representative images of that area should be obtained. Just one thing to note here is that the coronal and lambdoid sutures can actually normally have this beveled and slightly overlapping appearance. So this is a normal lambdoid suture down here. The sagittal suture is shown up here and should not have that overlapped or beveled appearance. Oops, sorry. So I'd encourage everybody to try scanning through the mastoid fontanelle on any baby, just to better assess the posterior fossa, but it's not included as a part of the routine scan in our SOP, and many centers don't include it as part of their routine scan, just because visibility can be quite variable through this window. That being said, if there is a clinical or sonographic question regarding potential pathology in the posterior fossa, axial images through the mastoid fontanelle should be obtained. In particular, it can be pretty good to assess for clot or some other obstructive abnormality of the fourth ventricle in the setting of hydrocephalus. It'd be useful to look in the posterior fossa for anything in the region of that fourth ventricle. In addition to representative transverse images, I would ask that ideally, if you're going to take images of the posterior fossa, it's useful to also obtain a cine sweep in transverse from superior through inferior, just to give a better idea to the radiologist of what's going on back there. Moving on to the neonatal spine, just a couple of notes around positioning to give you your best chance to get good imaging. The ideal positioning is with baby prone, with a pillow over over the lower abdomen to achieve a bit of a slight convexity of the lower spine. You can attempt a slight reverse Trendelenburg to try to distend the lower CSF space, just bringing by gravity the CSF down into the lower spine. In terms of imaging, things that we already do kind of routinely, but representative sagittal images of the lumbar spine, roughly from the T12 through L5 level. So that may be that may include, I think ideally 3 separate images in SAG from T12 through L5, another of the lumbosacral from L4 through S2, and then finally through sacrum. These should obviously include visibility of the spinal cord and termination of the conus, as well as appropriate labeling of the lumbar levels. And then a panoramic view is nice to have of the entire lumbosacral spine from T12 through coccyx. In larger or older babies, when you start to get a little bit more ossification of the posterior elements, it may be useful to image slightly off of the midline in a parasagittal plane to avoid any excessive shadowing from the spinous processes. So here you get that nice panoramic view from lower T through sacrum. So in terms of determining vertebral levels and appropriately labeling levels on your images, really the most reproducible method, there's no great method one way or another, but the most reproducible is identifying the lumbosacral junction based on the orientation of the vertebra, with the lumbar bodies lying in the horizontal plane, and then the sacral bodies starting to come off at an angle towards the probe, and then count up from that L5S1 junction. You can alternatively use the last rib-bearing vertebra as T12 or presumed to be T12, but this is less reliable because there is some variability in terms of the rib-bearing vertebra. Occasionally there is a 13th rib, so this is not as reliable a method. And then in terms of transverse images, really obtained through the lumbar disc levels, so L1, L2 through L4, L5. I would say if you encounter a thickened filum terminale, either thickened or abnormally echogenic, then there should be additional images obtained of that abnormal filum terminale, both in transverse and SAG, with and without measurements of the thickness. In terms of a couple of additional details around sacral dimples, or if that is the indication, which it often is, obviously, do a clinical exam when you're scanning to look for any obvious clinically evident sacral abnormalities, like a sinus, dimple, or skin lesion, like a hair tuft or hemangioma. This can be documented in writing on the worksheet, and then obviously obtain any obtained representative sagittal and transverse images of any sacral abnormality that's visualized, and try to demonstrate any deep communication with the spinal canal if you do indeed see that. I would also obtain a color image of any abnormality that you encounter in the subcutaneous tissues in this region. As with the assessment of any superficial or potentially compressible structures, a thick layer of gel should be used as a standoff when assessing for and obtaining images of any sinus tract. Other things with regards to the neonatal spine, document any abnormal fluid accumulations or mass within the visualized cord or the spinal canal with representative images, both grayscale and color Doppler, and with measurements, and also detailing the precise spinal level or position of that abnormality if encountered. And then finally, for spinal dysraphisms, not the easiest to appreciate with ultrasound, but if you do encounter a spinal dysraphism, obtain representative images of that dysraphism. Moving on to the neonatal hip, high frequency probe, linear probe should be used. In terms of positioning, kind of variable. Either you can have baby supine or lateral decubitus, obviously with the assistance of the guardians to stabilize the upper body and shoulder. Ideally, the hip should be in neutral position, so shouldn't be abducted or adducted away from the midline. And then really it's just placing the probe in a vertical position over the graded trochanter to obtain a mid-coronal section of the hip. And then there's specific anatomic landmarks that should be seen on any image that's going to be used for measurements. So we'll just go over that quickly now. These anatomic landmarks really need to be visible on any image if you're going to be using it to obtain a measurement. So that obviously should include the femoral head, which is going to be mostly hypoechoic, unless if the baby's age is a little bit advanced, then you may start to have some ossification centrally within it. But femoral head, the echogenic joint capsule, which is just this thin line, which is going to become continuous with the synovial fold over the lateral aspect of the femoral head. This triangular echogenic acetabular labrum at the lateral margin of the hypoechoic cartilage. So that this here is the acetabular roof cartilage, and then your echogenic labrum lateral to that. The bony roof, echogenic roof of the acetabulum, and the hypoechoic triradiate cartilage seen along the inframedial aspect of the acetabular roof. So to be considered suitable for measurement, in addition to just seeing those anatomic landmarks, there's also 3 conditions that should be met to again be dependable for your graph measurements. Essentially being able to visualize the transition from the echogenic ossified acetabular roof to the hypoechoic triradiate cartilage, which is kind of similar to just being able to see those 2 things independently, as was described previously, but just being able to see a nice transition from that echogenic to hypoechoic triradiate cartilage is one of the conditions that should be met. The wall of the lateral ileum should be straight and horizontal to the orientation of the probe, or parallel to the orientation of the probe. And then finally, the tip of that echogenic acetabular labrum should be visible. So for each hip, we obtain graph angles 3 separate times. Alpha angle is the angle between a line made along the ileal baseline and a line along the acetabular roof. So that's your alpha angle, and the corner of that angle is placed essentially at the corner of the bone or bony ileum from the lateral aspect to the acetabular roof. And then for the beta angle, again, your angle is between that ileal baseline and a line drawn through the superior aspect of the acetabular cartilage through the tip of the acetabular labrum. So here you can see that the point of that angle is a little bit further north of where the alpha angle was taken, just because that superior margin of the acetabular cartilage comes up a little bit higher. So you come from here and then through the tip of the labrum. In terms of femoral head coverage, again, obtained 3 separate times, essentially in the same plane as the graph angles. So moving on to some of the body pediatric protocols for pyloric stenosis. Typically, you're going to be presenting in the 2 to 8 week range, not uncommon, or not as common in the first week of life, and not very common beyond the 6th month of life, but still can occur, but very unlikely beyond 6 months. So Some discussion around patient preparation, as I think we're not entirely consistent in this regard, just because I don't think it's ever really been made to be consistent. But there are some techniques that we can employ to maximize our chances for good quality images of the pylorus. So to this end, prior to the exam, when available, baby should be fed with either Pedialyte or, if unavailable, sweetened water. I'm actually going to touch base with with the emerge department and see what can be done about potentially stocking this in our department for this purpose, because I don't think we routinely have this available to us, but I think it is quite useful to have. It's certainly certainly stocked in the ultrasound department at sick kids and used for this purpose. Feeding with milk prior to the exam should be expressly avoided. This can result in substantially more echogenic material in the stomach and can result in significant shadowing, as you may have encountered previously when baby's been fed just prior to the exam. So if in the event that the stomach is gas filled and obscuring the region of the antrum or pylorus, a couple of things can be done around positioning baby to try to bring fluid into the antrum and provide a nice window to view the pylorus. So baby can be placed in a right lateral decubitus or a right posterior oblique position to bring that fluid into the antrum and improve visibility. Additional Pedialyte or water can also be given if this doesn't sufficiently improve visibility. In the event that baby has had a milk meal, a significant milk meal immediately prior to scanning, left lateral decubitus position can potentially be helpful to bring the gastric contents away from the antrum into the body and fundus, and allow whatever fluid there is to layer into the antrum. Alternatively, you can use, again, the right lateral decubitus or RPO to bring some fluid into the antral region, particularly after giving a little bit more Pedialyte or sweetened water. And then in terms of the probe, I'm sure you're all familiar with what probe to be using, but small footprint probe, mid to high frequency. So in terms of the images to obtain, long and transverse images of the pylorus need to be obtained with measurements of the single wall muscle thickness twice for each, and then also obtain a pyloric canal length measurement in that long axis. A little bit less consistent and reliable a measurement than the single wall thickness, but should be obtained nevertheless. Unless obviously abnormal, I would say it really should be scanning for 15 minutes or so to interrogate the pylorus for any transient thickening, which can be seen in the setting of spasm or peristalsis. Usually that spasm or peristalsis is going to result in borderline thickening of 2.5 to 3 millimeter. If you're well under that, then it's normal. You don't really need to visualize for 15 minutes. Or if it's significantly thickened beyond that, 4 or 5 millimeter, then it's fairly abnormal and again, not as critical. It's this kind of borderline thickening that can result from peristalsis that you should visualize for a fair amount of time and make sure that it does persist and isn't just related to some transient spasm. So here, just demonstrating your long and transverse axis and how you should be measuring the pylorus in that axis. So here's your pyloric canal length, and then single wall thickness as measured, only measuring the hypoechoic muscularis externa portion of the wall. Shouldn't include any of the echogenic mucosa or serosa, or submucosa for that matter. One other thing that should be obtained routinely is at least you should be looking for passage of gastric contents through the pylorus, and if that is seen, then I'd ask that you try to attempt a cine loop, just showing that normal passage of contents through the pyloric canal. If the stomach is empty and you're really not getting a lot of motion through that pylorus, then can always give a little bit of fluid to try to stimulate that. So 10 to 15 milliliters of Pedialyte or sweetened water. One thing that's nice to show if you do encounter it is if you see an antral nipple, which is essentially a prolapse of the pyloric mucosa, this echogenic double layer pyloric mucosa and surrounding submucosa protruding into the distal antrum. Just obtain a grayscale image of that, which is nice. In terms of some additional images beyond just the pyloric images to obtain routinely in this exam, I'd ask that for any of these kind of neonatal exams that we obtain at least a single image showing the relation of the SMA and SMV with and without color. Useful also to have a cine sweep through the SMA kind of in the region of the pancreas, sweeping from cranial to caudal, just again showing a maintained normal relationship between those two vessels, no abnormal crossing. I would also ask that you'd obtain routinely images of the gallbladder in transverse and long in that region, and then just completing the examination of the upper abdomen with just representative images of the bowel in the right upper quadrant, left upper quadrant, and then you can also take a look at the lower quadrants as well. Mostly just looking for any other bowel pathology, thickening and dissection, anything else that would kind of potentially give rise to the clinical picture that pyloric stenosis presents with. Just going over the intussusception SOP. So typically, this is going to present later in the first year of life, peak incidence 5 to 9 months, but can occur at any time between 3 months and 3 years. Beyond 3 years, it becomes relatively rare, but older children can certainly be scanned for this in the appropriate clinical context. As for the technical considerations, in the event that there is significant bowel gas, particularly in the mid-abdomen, the child can be placed in lateral decubitus positions to bring the gas-filled loops up away from the table, and then the bowel that's closest to the examination table can be scanned in each position. So ascending colon would be scanned in the right lateral decubitus, descending colon in the left lateral decubitus. So for the bowel assessment, again, mid to high range frequency linear probe should be used, whatever highest frequency can be used that allows for adequate penetration. So with graded compression, large bowel should be scanned essentially from cecum to rectum with representative images obtained in transverse and long in each of the quadrants as shown here. I won't go through each one just for sake of time, but really of note, a vast majority of pediatric intussusception is going to be at the ileocecal valve, around 90% or greater, and generally without a pathologic lead point mass. So I think it's reasonable for sonographic interrogation to be most careful and detailed within the right hemiabdomen, because this is where you're going to encounter most of them. Usually they're most often obvious in the mid to upper abdomen, kind of just below the right lobe of liver. So reasonable again to start your examination here and see if you see an intussusception. If you see one, then you can further characterize it and continue on. But if you don't see anything in that region, then you can proceed to the systematic assessment of the remaining bowel. So small bowel intussusceptions can also occur in younger children and fairly commonly, mostly encountered in the mid abdomen or upper quadrant along the proximal bowel or proximal small bowel. Typically, these are fairly short, 3 to 4 centimeter in length, and are often transient and self-resolving. So if you do encounter it for whatever reason, then can take images, but this is less the concern than the ileocolic intussusceptions that may require some intervention. So what images need to be obtained if an intussusception is seen? Essentially, at minimum, static, long, and transverse grayscale images should be obtained with the quadrant in which the intussusception is found clearly labeled on the image. Cross-sectional measurement is not all that critical, but an attempt could be made to measure the intus in both planes, long and transverse. Color Doppler images should be obtained, looking for increased or decreased vascularity of the intussuscepted loops relative to normal bowel. And then, given potentially complex anatomy of the intus, cine loops can be quite useful for the reviewing rad to get a better appreciation for what's going on when the bowel is not straight and it is coming in and out of the plane of any static image. If you do see a lead point mass, obviously obtain representative grayscale and color images, as well as orthogonal 3D measurements of that mass. Similarly, if you encounter any trapped fluid within the intussusception or upstream dilated bowel loops, then you can obtain an image or two of those findings. So if the indication is for, classic presentation of intussusception, so we're talking current jelly stools, that colicky waves of coming and going pain, or really any other bowel specific complaints. If you see an intussusception, the study can be limited to this. If, however, the indication is more non-specific, like just abdominal pain, but they also say abdominal pain, rule out intussusception, or if you don't see an intussusception, then a full pediatric abdominal exam really should be performed. We shouldn't be limiting it just to the bowel if it's kind of more of a general indication. So that's it for kind of the pediatric specific protocols, but there have been some pediatric specific modifications that were made to the standing adult abdominal protocols, and there are standalone documents for the pediatric protocols for each one of these, if you do want to review them at some point. But I'll just highlight some of the key differences between the pediatric and abdominal exams for each one of these exams. So for the pediatric scrotal exam, pretty limited differences. Main difference is that the location of the testicle needs to be explicitly indicated on the image, worksheet, or both for each of the testicles. For an undescended testis within the inguinal canal, an attempt should be made to image the distance or measure the distance, approximate distance between the testicle and the inguinal ring, and there should be some indication whether the testicle is mobile or fixed within the canal. In terms of the gynae pelvis, a couple of more extensive key differences between this and the standard adult protocol. In terms of the prep for these patients, ideally you want to get good distension of the bladder prior to exam, because most of these patients are not going to go on to a transvaginal examination. Here there's some volumes that are suggested or recommended. I appreciate it may be hard to ensure that the child is going to drink this much, either because of patient tolerance or issues around timing and workflow, but try your best. Ideally, bladder should be filled to the point where the fundus of the bladder extends just beyond just cranial to the fundus of the uterus. But again, I wouldn't overly stress if this is not achieved in every single case. As for the expected images for the routine exam, it's fairly similar to the adult SOP, with the exception that for premenarchal girls, if there's really no suspicion of any Müllerian duct anomaly, then we don't need as extensive images of the uterus. Just a single long and transverse image, a long midline and then transverse fundal image is sufficient, rather than fundus, body, and lower uterine segment, so on and so forth. A couple of points regarding some specific indications or when specific sonographic findings are encountered. So one thing, if a uterine anomaly is encountered in the pediatric population, so we're talking about unicornuate uterus, didelphys, agenesis, or hypoplasia, then a complete renal KUB exam should also be performed as per the pediatric protocol. This is mainly because these obstructive Müllerian duct anomalies can frequently be seen in association with renal anomalies. Most often, it's just renal aplasia, unilateral renal aplasia, but can see other different anomalies with it as well. I'd ask that we include those if you do encounter any evidence of a uterine anomaly. If the indication is for precocious puberty, there's a measurement that we should try to obtain, which takes the transverse measurement of the uterine fundus with respect to the cervix to give a fundal cervical ratio. Anything that's greater than 2 would suggest estrogen stimulation of the uterus, and suggest that that patient is now postmenarchal. For this indication, I'd also ask that we obtain a 3D volumetric measurement of each ovary if not already being obtained, and document obviously any ovarian cysts, any enlarged ovarian cysts. In this context, you might see a daughter cyst appearance with the large cyst and the smaller cyst inside the cyst, which is a normal benign finding, but can be seen in this setting. One last point about clinical indication. So for PCOS, investigation of PCOS, I think this is something that is also included in the adult protocol, but is still not being done consistently across the board. We need to have a count of the number of follicles. If it's too difficult to count the number of follicles, at minimum, a cine sweep of each ovary needs to be obtained so that the radiologist can actually count the number of follicles afterwards, as this is one of the determinants of whether or not the patient actually does have polycystic ovaries or not, is the number of follicles that there are. So we need to have a good idea of that, and then obviously a 3-dimensional volumetric measurement. In terms of the API protocol, one thing to mention, I would say that this protocol really should be selectively only applied in the pediatric population over a certain age and level of maturity. So generally, we're talking in the 8 to 10 year or older range. Below that, the reliability of the patient description of symptoms is kind of low. And if the exam is being done for generalized abdominal pain or fever, and it's the patient's first ultrasound for that particular presentation, then really a full abdomen should be included in this. I mean, our API protocol already includes most of the abdomen anyways. It really would just be the left kidney and spleen that we usually don't include in this. But I would ask if the patient is younger, then I think we should be including those organs as a standard. So one addition to the pediatric API protocol is interrogation of the bowel in the lower quadrants, pelvis and periumbilical region that we don't commonly do in the adult population. Really, it's good practice in any API protocol, regardless of age, but particularly in younger patients. Notably, the bowel should be interrogated for any thickening, abnormal bowel motion, so any hyperperistaltic loops, or any hyperemia. And if you do encounter hyperperistalsis or hyperemia, then either cine loops or color Doppler images should be obtained respectively. The other thing that is also included in both the PEDS protocol and adult protocol, but I find is kind of done a little bit inconsistently, is we should be obtaining images of the terminal ileum in addition to the API if you do see it. And regardless of whether or not you see the API, we should be getting an image of that terminal ileum. First of all, this documents that you're interrogating the correct area. I mean, it's mostly not in question, but definitively shows on images you're scanning in the right area. If the API is seen, then this is demonstrating that the tubular structure that you're imaging and calling the API is not terminal ileum, because we have a separate terminal ileum. But also, not uncommon to have an inflammatory enteritis like Crohn's or even, infectious enteritis presenting clinically like an API. And the terminal ileum is frequently involved in these cases and can show, abnormal thickening or hyperemia, something to suggest that there's an alternative pathology to appendicitis that's causing this presentation. So with regards to the pediatric kidneys, one thing that we already do with the pediatric kidneys routinely is measuring the AP distance of the renal pelvis when visible. But one thing I don't see all that consistently, and I'd like to see included is we really should be obtaining an AP measurement of both the infrarenal pelvis and extrarenal pelvis if they're drastically different. The extrarenal pelvis is less clinically relevant when assessing for hydro. You can just have prominent extrarenal pelvises. That intrarenal pelvic diameter is a little bit more important, but if you do see differences between those two, then I'd ask that you obtain AP measurements of both. One thing that's also included in the pediatric renal protocol that's not routinely done in adults is that the kidneys should be interrogated with a linear high frequency probe to assess the renal cortex and medulla with representative images obtained. I just note that in neonates, the renal cortex is normally a little bit increased, but becomes isoechoic to slightly hypoechoic relative to liver and spleen in the first year of life. And the medulla can be quite markedly hypoechoic in neonates. That early 1 to 2 week period can be quite drastically hypoechoic, and that's perfectly normal. So if you do see that, then don't be alarmed. That's a normal finding. In all younger children, really, I would say an attempt should also be made to interrogate the suprarenal fossa, looking for a normal adrenal gland or any suprarenal fossa mass, and then obtain a representative image if you are able to see a normal adrenal, or obviously if you see a suprarenal mass. So we're almost at the end, so just bear with me. I think there's just 2 more slides. So as with the female pelvic protocol, renal and Müllerian abnormalities again tend to exist. So if any renal anomaly is detected, so that being renal agenesis or dysplasia, horseshoe kidney, crossed fused ectopia, or a duplex renal collecting system, then a female pelvic protocol should also be added to the kidneys to look for any Müllerian abnormalities. And just a note that bladder volumes don't need to be routinely obtained in the pediatric population unless there's a appropriate clinical indication, or if you do encounter hydro, you can see if baby can go to the washroom, or the child can go to the washroom, and then obtain another look at the kidneys afterwards to see if that hydro has resolved. So yeah, final slide. Just a couple of notes about some limited differences between the pediatric abdomen and the adult abdomen. So again, all pediatric abdomens should include documentation of normal SMA and SMV relation with those static transverse images, as well as a cine sweep, just showing that there is any abnormal crossing of those vessels. For neonates, if there's any clinical or sonographic suspicion for biliary atresia, then we really should be looking with a high resolution linear probe in the region of the gallbladder fossa and periportal biliary tree, looking at the gallbladder if it's there, and measuring the gallbladder for size. You can see a small gallbladder in some of these cases, and looking for any ancillary findings like the triangular cord sign that you can see here within the porta. And then the last thing, I think pediatric abdomens should routinely include images of the urinary bladder. So that would include measurements of wall thickness if it's abnormal. Any specific abnormalities like dilated ureters, urachal cysts, polyps, masses, debris. If you do see debris, then again, a cine clip showing the mobility of that debris. And that's pretty much it. So hopefully it wasn't too quick. Again, this has been recorded, so I'll put that up if you do want to review it at some later point. I'll also post up the slides as well that go over kind of just the limited changes from the adult protocols for those that are relevant. So if there's any questions, I'll take any questions now. I saw that Shalinder noted that. So that we have Enfamil 5. Okay, great. So I appreciate that we can order them through Meditech, which is useful. But I think it'd be nice to be able to actually stock them in departments, so we don't have to wait for them to be brought over. I don't know if that's what you're referring to, if we can just order them through Meditech and then stock them, or if we would have to order them. Okay, great. Yeah, so I'll see if we can do the same at MQ, maybe a little bit more challenging. I don't think we see these patients for that indication at Q nearly as commonly, but I'll see what we can do about making sure that we do have at least some limited stock at all of the, or within all of the departments to accommodate for that. Okay, yeah, great. Yeah, I would imagine that Emerge is probably the easiest way to source these things, but if that's at all inconsistent, then we can always make sure that we do have a stock as well. If there's no other questions, we'll wrap up now. Thanks again for joining. And if you do happen to have any questions that come up, or thoughts or comments, feel free to reach out, message on Sectra, email, call, anything. All right. Thanks again, everybody.